Welcome to this short educational session about a dialysis and a therapeutic renal replacement therapy modality that has been forgotten since the 1980s, early 80s and late 70s. And the reason is that now with advancements of dialysis technology, portable machines, portable reverse osmosis water treatment systems, dialysis, whether it's chronic or especially acute dialysis in the intensive care unit for patients who suffer from acute renal failure, has now been replaced with these technological advancement machines and reverse osmosis and actually portability and availability. Unfortunately, there has been some unforeseen circumstances in the world today that make a need for resurrection of this modality, or what we used to call resurrection of a dinosaur, and Back to the Future as a modality for treatment of acute renal failure in the intensive care units for patients who really do not have a choice based on distance, lack of ability for transportation, war areas, unsafe areas, bombardment, bombing, and earthquakes or natural disasters. So there needs to be a modality that we can resurrect and use in a simple way to help patients with acute renal failure, to treat them until a definite therapy has arrived or patient is safely be able to transfer somewhere else, or most importantly, they recover hopefully from their acute renal failure, because most of these acute renal failures in the intensive care unit settings related to war injuries, blast injuries, rhabdomyolysis, and natural disasters are very short-lived and actually should recover very nicely and very quickly. So this modality that I'm going to be explaining today, it's called continuous arterial venous hemofiltration. Actually, there is no dialysis, but we do clearance through convection. And as we go along, I'll explain to you the setup, and then down the road, the basic equipment that are needed, and eventually we'll be able to find a way we can become a practical modality, not the ideal modality, but a practical modality in hopeless situations or in situations where acute dialysis is not available. So first, I'm going to start with the name. It's called continuous arteriovenous hemofiltration. So in order to have a continuous and arteriovenous, you have to have an arterial access and a venous access. And it's preferably to have both of them on the opposite large limbs. You cannot have the arterial and the venous access on one side or on this side, and the reason is if you have a removal, if you remove these catheters afterwards, and they have two adjacent holes in the artery and the vein, there is a chance of AV fistula down the road. The other issue is that if you have a lot of catheters plugging one arterial and venous system in one limb, the risk of ischemia of that limb is a little bit higher. So it's preferred to use one side for arterial access and one side for venous access. This is an arterial catheter. If you notice, it's a single lumen catheter. And this is a venous access, which is a conventional hemodialysis catheter, but it's called trialysis because the middle port can be used as a PICC line, and this is a return line, and this is also a return line even though it's in red. So the premise and the principle of this procedure is actually utilizing the systolic blood pressure. When you have a mean arterial pressure around 80, you have about between 100 to 150 mils per minute of arterial blood flow that we can take from the artery and return to the vein by passing through a dialysis filter. And that filter gets positioned between the legs, and that filter is what really leads to clearance. And this simple arterial catheter is about 7.5 or 8 French catheter. The advantage of this catheter is that it can be introduced to a classic Seldinger technique. And this is not the right opportunity to describe Seldinger technique. With a little bit of skills and a little bit of experience, insertion of this catheter is relatively easy in skilled hands, and it's a very common procedure through Seldinger technique. But this catheter has actually a stiff introducer to be able to introduce it to the artery. And then that's removed after the end of the insertion procedure. But the two main advantages for this catheter is, number one, it has a clamp and actually closing the artery. So if you get through and you want to secure that artery from not having return blood flow, you can clamp it. The other advantage that this catheter has, it has a wing where silk or nylon stitches can be used to secure the catheter to the skin so it will be safe and stable. So that catheter is going to be introduced in the right femoral artery through a classic Seldinger technique, and the outcome would look like this, where that catheter is actually in the femoral artery and it is secured with nylon stitches, and then that artery or arterial catheter can be clamped until it's time to use it for our continuous arteriovenous hemofiltration. The other access that we need is the venous catheter. The venous catheter is also a classic dialysis catheter that can be inserted into the left femoral vein. And the purpose of utilizing a dialysis venous catheter, because it has multiple ports, a minimum of 2. This is a unique catheter that's called a trialysis that has 3. But we can return blood through one catheter in the venous system. We can use a triple lumen in the neck, or a PICC line in the arm, or the left femoral vein. But these 2 additional ports can be utilized to infuse IV fluids, IV antibiotics, hyperalimentation, and so forth. So this catheter is going to be inserted in the left femoral vein as such. Now, you don't necessarily have to have them this way. The arterial axis can be on this side and the venous axis can be on this side, but it has to be both sides on the opposite legs. Since this is a forgotten modality, this tubing has not been specifically made for CAVH, but this tubing meets the needs and the structural as well as functional needs for CAVH. This is a blood tubing from traditional and conventional hemodialysis machine, and it's called the streamline tubing, which is a Fresenius machine fitting for outpatient chronic hemodialysis, as well as using a conventional dialysis machine. But this tube has a what I would call an patient side or a catheter side, which is a male classic traditional Luer lock that will fit tightly in the Luer lock of the arterial catheter, and it can be sealed by securing the catheter through its kit or the cover that can be twisted tight to secure this fitting so it will not get loose. Remember, we have arterial access and the artery is clamped, and also we have the first piece or the first item you find in your catheter is actually also a clamp on the catheter to reduce the risk of having fluids run back or blood going this way if you don't want it to go that way. So the first piece is the red clamp on that catheter, and then the next connection or the next item you find in that blood line is actually what I would call the medicine port. This medicine port is a tight port that can be utilized to securely insert the male part of the Luer lock for infusions. This port can specifically be used for normal saline flushes, 250 cc's every hour or so, or periodically to diagnose whether the filter is clotted. So if a patient has low platelets, bleeding tendency, and you don't want to use heparin, and you want to flush periodically to reduce the incidence of filter thrombosis and clotting, then you can use the first port, which is called the medicine port, to infuse normal saline either at 250 cc's every hour or so, or if you want to diagnose clotting, you can use 50 cc's and observe The next port you see is actually an arterial sensor. And since this tubing is not made and designed for CAVH, there is no clinical use in CAVH for this segment. And this is an arterial chamber, but keep in mind this is actually sealed and there will be no fluid nor water can come out nor blood. So it can be just covered with a cap just for the sake of security, but there is actually no need for that. And a piece of a 2x2 and then a tape can be used to secure this so people will not access this nor utilize it. The next part that you will see on your tubing is actually what I would call the pump segment. This is a larger segment of the tubing, but again, this was designed for a conventional dialysis machine. So you can see the segment of tubing is a little bit larger and it interrupts the traditional blood flow, but again, it has no function for our CAVH. The next part that we see is actually a double lumen. This part that has a clip at the end can be used for heparin infusion or heparin flushes. So if you have a patient that you want to use CAVH but they don't have any bleeding tendency and their platelets count is okay and they need to be either placed on continuous heparin infusion or they need to be provided with boluses of heparin, whether there is a IV pump that can deliver about 1,000 units per hour or so, or you can actually inject that in the form of boluses every hour. This is the right port to infuse it, and then after you infuse it, you can actually clamp the catheter, and then you would have security that there is no blood return. This catheter should remain clear because that is either a heparin infusion or heparin flushes. Now the other arm of the terminal end of the catheter is what we call the filter or hemofilter or dialyzer end. This fitting has a cap on it. Remember, there's no clamp. It's a cap, or you undo the cap and then you connect that to what I would call the hematic end of the hemofilter. The hemofilter has a longitudinal axis and two side ports. So the longitudinal axis from one end to another is actually where the hematic ends or the blood ends of the hemofilter. This is not only a lower lock, but there is a ability to place it in here and securely tighten that to the point that it is very tight and there is no water, air, or blood leak through that hole. Again, this is the longitudinal axis and these are the hematic ends. On this side we connected the arterial connection, and on this side we will connect the venous connection that returns back to the venous return. Now if you notice on this side, these are the side ports where ultrafiltrate will come out, and the ultrafiltrate or the filtrate will come out is actually what leads to clearance of the uremic toxins, electrolytes, potassium, and lactates and acids through filtration and through convection rather than through osmosis and dialysis. So there would be no dialysate running through this. It would be one port is going to be utilized to really allow filtrate to come through here. So before we talked about coming out, I'm going to show you the connection back from the other end of the hematic ends through the longitudinal axis of the hemodialyzer back to the patients. So if we take exactly identical tubings, and that tubing is actually has two ends, hemofilter end, it will fit, it has a cap. You remove the cap, it will fit tightly and securely, and you twist it so tight that it will no longer have water or air leaking, and it will form a tight seal. Then that will have, the first thing is going to have again a medicine infusion port, and we can use this port to infuse replacement fluid or bicarbonate fluids or any other fluids like antibiotics or hyperalimentation. And then after that we clamp this, and it's a tight clamp to make sure that there is no blood return into the system. And if you see at one time while you're running this blood return, all what you have to do is just flush it with saline. Again, this big segment is actually called the pump segment, and this tubing is not designed for CAVH, so we will ignore this. Again, this is the pressure monitor or pressure sensor. Make sure that sometimes it's nice to have a syringe or a cap at the end and put a tape around it so nobody will access it nor use it. Again, this is also a medicine port where you can use a lower lock technology to insert it and tighten it and get access into the main circulation. And again, this is the patient end of the tubing, which is a male lower lock, and here's a clamp, and then it can be used to be inserted in any of these ports, because all of them are venous ports, even though one of them is red. And what we call in the world of dialysis or nephrology, this is the arterial port of the dialysis catheter, but it's actually not an arterial port, it's actually a venous port. And this is also a venous port, and this is a venous port. So any one of these three can be used. Keep in mind, this is the most distal at the tip of the catheter, then it's this one, then this one comes the most proximal. So if you infuse the blood through this one, this is going to go straight to the heart before it mixes with this. And keep that in mind. So when we're talking about calcium replacement, bicarbonate replacement, and so forth, it's nice to know that it's better to connect bicarbonate in the most distal port and the blood return to the most proximal port as such. So you insert it, and then this is a locking technology. That locking technology, it can be twisted, and when it's twisted, it truly secure the catheter and the tubing together that it will not get loose. So this securing technology on both sides is a twisting technology that will lock the catheter and the tubing together. Then for safety reasons, there's also clamp on the arterial side or on the venous return side here, as well as there's clamp on this side. So once you connect all this, you have a closed circuit. If you open the artery, open the tubing, then you'll have a blood going out, passing through the one end of the filter, coming out at the other end of the filter, and returning back to the patient. So now we have an artificial kidney that sees arterial blood and return to the venous system. And what we need to do is then open one of these ports, what we call the side ports, and allow filtrate to leak. And actually what would happen there, it would be about 500 cc's an hour of filtrate, and that is the average amount of filtrate that can leak. So we may have to catch up with IV fluids, what we call replacement fluids. Keep in mind, if the blood pressure drops, then the filtrate will be lower. If the blood pressure is higher, then the filtration will be higher. If there's a kink or a elevation in the venous pressure, like the catheter is clogged or kinked, then you have a lot of resistance in the venous circuit, so the filtration will be even higher. Sometimes if the filtration is a lot lower, you may have actual clotting inside the catheter. Now, which port that is actually need to remain open? It is actually the port that is closer to the venous return. And once we talk about priming, I will show you why the one that is closer to the venous return is the one that need to remain open. As we go through the collection of the filtration, this is a very simple piece of clear tubing, or actually a clear hose you get from any stores that sell basic home equipment. and this is a clear hose that you can connect it in this port. Keep in mind, this side is not a sterile side. And then you can connect a regular catheter tubing, not actually the indwelling Foley catheter, but the tubing end that connects to the indwelling catheter. You can connect that and collect filtration. And keep in mind that if this becomes bloody, that means there are some fiber ruptures. If this stops or declined by about 25% for a period of 3 hours, there's most likely clotting in the fibers as well. If it's completely ceases, then you know there may be a arterial kinking, and if it goes haywire like 1,000 cc's per hour, that means probably the blood pressure is higher, or you may have a venous kinking or a venous resistance. So the basic technology depends on systolic blood pressure, connect to a filter, filtration, venous return. And if all what you do is pinch this, then you can stop filtration. So if you look at this, you can pinch it and then put a hemostat here so you can stop filtration if a patient is hypotensive, or you can pinch it a little bit or even open it completely if your blood pressure is high and the patient is having a lot of filtration.